Welcome to Women of Impact in Anesthesiology. I'd like to introduce today Dr. Alice Coombs, Professor and Chair of the Department of Anesthesiology at Virginia Commonwealth University. Thank you for joining me today. For those of us who may not know you very well, can you please give me a brief summary about yourself?
Thank you. Well, I came into the field of anesthesiology in an indirect way, but I'm here. I was initially interested in internal medicine. I've always been interested in anesthesia, but when I first tried to pursue anesthesia in medical school at UCLA, my advisor told me that the field of anesthesia was for people who couldn't get into other residencies and were from outside the United States. They trained outside the United States. So he said it was a quote unquote low esteemed profession. That was back in the late 70s. And I even wanted to go into anesthesia back then, so much so that I did a preceptorship in anesthesiology. But because of the discouragement, I actually went into internal medicine, which I liked as well. And I matched at Mass General Hospital in internal medicine. And I loved internal medicine. But after completing internal medicine, I really still wanted to go into anesthesia. And I applied for the anesthesia residency after being in private practice for a year and a few months, and went back into residency at Mass General in anesthesiology, after which I absolutely loved anesthesia. And I did a critical care medicine fellowship at Mass General as well. And then I followed with a cardiothoracic anesthesia fellowship at Tufts University, where I stayed on staff, and I was one of the directors of the surgical intensive care unit a long time ago. As you know, in the Northeast, they have a lot of models where the anesthesiologist is actually will direct the medical ICU, the surgical ICUs. So my background is from Compton, California. I grew up in a area that was pretty rough. I went to UCLA, and I wanted to be a doctor because I saw healthcare disparities in my neighborhood, and I wanted to make a difference in people's outcomes.
Thank you for your story. It's really unique and a great inspiration for all of us. As a young attending, did you think you would be where you are now?
No, not really. My first love is really, I love the science of medicine. I love practicing medicine. I love bedside medicine. I really am passionate about healthcare disparities and how vulnerable populations suffer adversely. So because of that, I have a deep passion for healthcare reform and a healthcare policy. And so I've been working in healthcare policy for years. I recently actually obtained a master's in public administration from the Harvard Kennedy School about 9-10 years ago. And I will tell you that medical school does not prepare you to deal with issues around payment reform, around healthcare delivery systems. And my eyes were open when it came to understanding more about healthcare economics and how healthcare happens in the United States, and how some populations suffer adversely. And I don't have to tell you, but you know that some of our statistics among subpopulations of Latinos and African Americans are worse than third world countries. That is an appalling fact. And that has motivated me to do the things I do in medicine. And coming to VCU a few years ago, I think one of the things that really excited me was the fact that it serves a population that has so many struggles and challenges with social determinants of health. Unlike many of the communities where I trained, Boston does have issues around that, but this is staggering. This is the compelling. The patients I see, the issues that they struggle with, far worse in this area. And so I felt that there was a niche for me to really make an inroads into how patients, and in terms of the patient outcomes, through creation of policies and protocols to address healthcare disparities, everything including what's the impact of ERAS on social determinants of health. Is there a way in which you can develop protocols to address some of the issues around perioperative outcomes? And we saw in the ARC study some of the summary of some of the data, as well as the archives of surgery, that even in elite institutions, we have minority patients who will come into high volume institutions where, say, it's a high volume cardiac surgery service. They will get the low volume providers and be subject to worse outcomes. So because you come to, these amazing medical centers, even under those medical centers, instead of you getting the high volumes provider, you will absolutely be surprised at the outcomes with minority patients, because many of them receive care from low volume providers. And that's something that I think needs to be addressed in terms of healthcare literacy and empowerment with patients.
This is an important arena, especially for anesthesia, because we do have an influence, even though we may not realize we do. Going back a little bit on you going ahead and pursuing your master's in public administration, what doors opened for you for pursuing this degree?
One of the reasons why I actually became very interested in a master's in public administration is because I've been in leadership and advocacy organizations. So in 2010, I became the president of the Massachusetts Medical Society, the oldest continuous medical society in the country, and the owner and publisher of the New England Journal of Medicine. And as a result of being engaged and very active early on, I became active in various activities, even before becoming president. And one of the things is that I was appointed to the Governor's Payment Reform Commission in Massachusetts, Governor Deval Patrick. And what was amazing is that I began to learn and understand some of the issues that were on the table for patients and for physicians. And one of the issues I think became very obvious was that this whole notion of global payment and how that impacted physicians. But how did that impact physicians taking care of minority patients or poor white patients? How did that impact physicians who were taking care of patients that were disproportionately on Medicaid or Medicare? And so I began to really delve into this whole notion of payment reform and public policy and what that does to physicians. And believe it or not, it affects every single physician. Anesthesiologists are no exception. And so with that being said, I really saw that there was a need for me to understand healthcare economics, to understand the whole issue of supply demand, but also behavioral economics. And going to Harvard Kennedy School allowed me to study a lot in the area of behavioral economics, which is so related to medicine, not just on the patient side, but even on the physician decision-making side. The whole thing of anchoring biases and, the confirmation bias and how we make decisions around care, and how we can actually be dogmatic about our decisions and our diagnosis. And we need to step back and consider the fact that there may be another alternative, and it causes us harm to the patient when we are afraid to be wrong. And so this whole notion of what does it cost you because you have this understanding that you want to be right at all costs. And I find that in medicine, that is a prevalent theme, is that people have a difficult time saying, that is a possible scenario, not just with diagnosis, but with bigger things like allocation of resources and distribution of monies within a healthcare system. I'll give you an example. Anesthesiologists are hospital-based physicians, right?
Yes. Mm-hmm.
So when the healthcare system president looks at productivity and they measure productivity based on how many dollars generated, that's a problem. They look at productivity based on ASA units, and that alone, that's a problem. And so our goal as anesthesiology leaders is to really persuade people to understand a different way of thinking. They have to be able to convince, negotiate, advocate for leaders to think again. For instance, it is not considered a product, an element of productivity on the financial side for anesthesiologists to be covering the PACU or to be operating the pre-op clinic, the PACE clinic.
Mm-hmm.
That is not what the bean counters will understand as productivity. They're looking solely on dollars generated. Well, if they wanted to do something really clever, they would actually look at cost accounting. You do not learn cost accounting in medical school. And that says things like this. We don't think this way. That says things like this. If you're covering the PACU and the hospital gets a facility charge for each one of those patients, how do you actually attribute or allocate the monies that are being generated from having that PACU to the anesthesiology service that's actually covering that?
Mm-hmm.
Now, have you ever seen that happen?
Mm-hmm. No.
Exactly. And so going to the Kennedy School got me to think very differently about how even someone measures the productivity of a hospital-based group. I'll give you another example. In the emergency room may not have the productivity of a cardiology service, but consider an emergency room that actually houses patients because there's no beds inside the hospital to take care. So to take care of the patients, they're bordering in the emergency room. Guess what? Cost allocation says how much of the cost of that day rate that's being generated is given to the hospital facility when it should be reallocated to the emergency department, which continues to care for those patients, regardless of whether or not the team comes down to admit the patient. So it's things like that, medicine doesn't train you to deal with cost allocation and then the whole notion of how does a department deal with a budget and funds flow? I mean, those are the kind of things that are innovative, that allows a department to say, you give me this budget, it is predicated on a grid that's created to address all the demands within the healthcare system. It's fascinating. You say you want us to cover a new community hospital, there's a pro forma that I have to draft. And guess what? That was your clinical mission and your clinical expansion at the healthcare system level. People as leaders decided that they wanted to do that. Don't tell me we're starting something you expect us to be highly productive. Because the initiation of any kind of clinical expansion in the early phases is not going to be a cash generator. It takes a while before you generate the revenue. I mean, it takes a while for you to generate the revenue that you need. So no, it helped me to think differently. I would really encourage and advocate for anesthesiologists, to get advanced degrees, whether it's an MBA, an MPA, because it allows you to really negotiate when you're at the table. It allows you to contend with the financiers who are sitting there, who are telling you your productivity is not on par with, for instance, cardiology.
Yeah, I'm sure that's been really helpful for you in your position. But it's important for other anesthesiologists who work in leadership positions to also have these ideas and understandings to further the department. What leadership roles early on in your career were most influential for you in attaining your current position as chair?
I think one thing that really helped me to be in the position I'm in right now is that I was chair of a hospital department of anesthesia years ago. And I was in a private practice for years.
Mhm.
And in private practice, you will have colleagues that you work with very closely,
Mhm.
and you know each other's life, you know the spouses, you know the children. I think one of the things that it really helps in private practice is the collegiality that you have.
Mhm.
And learning from my colleagues at South Shore Hospital has been absolutely phenomenal. You're like a family. I
Mhm.
was the first woman in my group in the private practice, and it was interesting. They went through a transition. I never forget going to the first corporate meeting and getting up from the chair, and one of the guys joked with me and said, "Hey, are you going to clean up after us?" A lot of women would have been offended, but I just kind of looked at them like, "No, not today." But it's interesting that the same individual who did that, I became very close with him. And they were learning too. I mean, some things that are said with new cultural adaptation, I would allow it to be a learning experience.
Mhm.
But speak up. You know, there's no role for being a chameleon in a group that needs to learn. And I would have denied them the opportunity to learn from me. I can learn from you, but you know what? I'm not going to deny you the opportunity for allowing you to see what I actually think. I think that's where people are afraid to take risk and to speak up. I could actually be in silence, or I can act out, or I can say, let me communicate in an effective way. It really taught me how to communicate, how to work through system issues with patient care, draft a protocol. I'll never forget one issue. I'm a critical care doc as well, with a patient on the floor who had been placed on an insulin drip. And we get the, cold call that there's a young 16-year-old guy who's unresponsive on an insulin drip on the floor. Well, it scared me to death. I was really petrified about this. And I said, you know what? We have got to create a system that does not allow this to happen ever again. And in my next ensuing 20, 25 years there, it never happened again. But running an insulin infusion on the floor is something someone thought is novel. We don't have to put them in the ICU. But so many things come up like that. And people say, well, that's a one-off. No, it's a one-off. But if a patient is found hypoglycemic in bed and actually has seizures, or it results in an even worse outcome, that is not a one-off. That's a one-off, what you say for you, but that is someone's loved one. And I think you have to address the one-offs to make sure they don't happen again. I believe in doing system changes for quality. And so I've worked with quality for a long time. I was on the board of registration in medicine in Massachusetts as well. And that was very helpful. I was the vice chair of the patient care assessment on the board of registration of medicine in Massachusetts. That was a leadership position that was very helpful. And then probably one of the positions that I really do, I will always cherish, is being the a commissioner for the federal government on the Medicare Payment Advisory Commission. And I was able to be in that environment and bring the patient in the room. So many times we would have the epidemiologists from Harvard, we would have the actuaries, we would have the economists from all over. We'd have, some doctors who were plan doctors. We would have the plans there, the insurance plans. So there were a number of other individuals and stakeholders at the table. But my goal was, there's nobody in here that can bring the patient in the room. And I would bring a case and say, this is a scenario that patients are having to deal with. That made it would persuade them to do things that they would not have considered.
Mhm. Mhm.
An example, someone had proposed that PSA should never be paid for in patients older than 65 years of age on Medicare.
Hmm.
And on first blush, and I think the task force actually looked at that and they supported it at one time. But then we realized that African American males, they do die of prostate cancer, and it's a painful death. And detecting prostate cancer early in the course should be the option for any male.
Mhm.
And so not being able to do the test because it's not paid for, that would cause people to make default decision making. Well, Medicare doesn't pay for it. So I argued that by saying, look at how African American males suffer as a result of prostate cancer. So many examples. I could give you many examples. And part of it is being in the operating room taking care of a patient who's having a prostatectomy.
Mhm. 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 That's great that you can bring these examples to life to people who may not see or understand the implications for their treatment and their outcomes. So it's wonderful that you're able to do that. What prompted you to decide to pursue a chair position of an anesthesia department? I'm sure that's not an easy decision.
No, it really wasn't something that actually, when I came to VCU, I even thought about.
Mm-hmm.
So I can actually say that Dr. John Butterworth was one of the individuals who mentored me. He was a sponsor to me. He was an ally, and really encouraged me and guided me through this whole process. So I would say that one of the things that was really important was his mentorship, and that really resulted in my wanting to be chair more than anything else, and the fact that I knew that I could do a good job. Part of use when someone asks you or encourages you to do pursue an area, no matter what it is. One of the things that someone once told me is that if you start thinking about that and what you would do differently, if you really begin to perseverate on, I would do this and I would do that and I would change this, and you have that energy that's bubbling inside of you, that's a good sign.
Mm-hmm.
But if someone says, Dr. Coombs, would you like to chair the department, and it's repulsive, and you say, oh my goodness, that's the time that you really have to question what you're doing.
Mm-hmm. 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 What has been your biggest challenge as a chair of an anesthesia department?
Well, I guess one of the greatest challenges is actually dealing with divergent views about practice roles.
Mm-hmm. Mm-hmm.
So coming into a system, coming from a private practice, there are so many opportunities to really make inroads into patients' care. My group was incredible in that if one of my partners said, I need X, Y, and Z from you, I'm going to be leaving at 5 o'clock. We would write down what was necessary and follow through. That person could leave and never doubt whether or not something was done or followed through. Mm-hmm. But even though that person left, they may even still call back at 9 o'clock. It's done. Mm-hmm. But that was a kind of behavior, and that was a kind of conviction, that and very conviction of, I really care about this patient. I'm just calling to check in. How's everything going? Tenacity to follow through. That is born in groups where you have this kind of close relationship, and it is in academics. But I know for sure, being in a private practice where people's practice styles become amalgamated, and you kind of if you were in the office, you're talking about what you did differently and how someone else can learn from it. But it's an amazing transparency between colleagues, and that's a little different coming into an academic setting. There's more of a divisions, and there's probably a little bit more different styles within the same group. Mm-hmm. And you probably have experienced something like that. Mm-hmm. But I think coming from a private practice, I will always appreciate the seamless care. And I think there's seamless care amongst some groups in the academic practice, but overall in the private practice, I can appreciate the seamless care. Mm-hmm. I can appreciate the tenacity to details, follow through. We're not talking about someone who just leaves and just, so expectation is probably one of the things that I think has been a little different for me. Mm-hmm. Roles played, but when you get to the large systems, you really need to have a rubric for people to say, these are the guardrails and I got to stay within them. And if these things happen, I know what I got to do. Because everybody thinks differently, especially in crisis management.
Mm-hmm. Mm-hmm. Yeah, it's so true. It's interesting that you said the difference between private practice and academic center practice. The group that I work with right now, their background is a private practice that ended up being bought out by the hospital. We all practice very similar. Like we all follow the same, very similar to what you said. We follow the same, path, and we very few of us divert from that path because we all know it works, especially for our system. Our pre-op, our PACU, all the recovery and our hospital. And it's interesting when other people come from larger institutions to our smaller group and they have a hard time fitting in because they don't recognize how small we are and how much is all on you. Like you have to do it because there's no resident, there's no fellow, there's no one else. You have to do it. And a lot of them kind of struggle initially when they join our group because of that. So it's interesting that you said that.
I do want to say, I didn't say this earlier, but I need to say this. Mm-hmm. One of the most important persons in my life were my parents, who really taught me about giving. My mother used to go throughout the neighborhood, basically taking food to the sick and shut in. That's where my desire to pursue medicine came from. I also would like to thank my mentor, Dr. Marlene Myers, who back in the day in Mass General was one of the most important persons who encouraged me. She stood up for me. She took up for a person who was one of the few African Americans at Mass General. Mm-hmm. And she needed to, at a time when I was most vulnerable and even considering quitting medicine and quitting anesthesia. And I appreciate her. She made me stronger. And so to Marlene, I give her tribute to her. Awesome woman.
Thank you. Thank you for sharing, and thank you for your time. It's been wonderful talking to you. And again, thank you for sharing all your experiences. I've learned a lot from you today, and I'm sure others do.